CCMA EKG Study Part 2. Preparing the patient for EKG. Do not move talk once leads are connected. Undress from waist up and have lower legs ankles accessible. Drape or gown opening in front. Remove all jewelry and turn off electronic devices. Do not apply lotions, oils, alcohol wipes used at lead attachment sites. May need to shave hair. Ratio of applied leads to recorded leads. 10-12. EKG vertical axis. Amplitude. Each small vertical square equals 0.1 megavolts. Each large square equals 0.5 megavolts. EKG horizontal axis. Time. Each small horizontal square equals 0.04 seconds. Each large square equals 0.2 seconds. Characteristics of EKG paper. Pressure and heat sensitive. Normal speed for EKG. 25 millimeters per second. Normal amplitude of EKG. 10 millimeters. How to attach EKG limb leads. Place on fleshy areas of the skin and within the same general vicinity on each limb. If one leg is amputated, place electrode on the abdomen, and the electrode for the other limb should also be placed on the abdomen. Place on fleshy areas of the skin and within the same general vicinity on each limb. If one leg is amputated, place electrode on the abdomen, and the electrode for the other limb should also be placed on the abdomen. Bipolar limb leads. 1, 2, and 3 impulses travel from negative to positive pole at specific positions in the heart. Lead 1. Records impulses between left and right arms. Lead 2. Records impulses between right arm and left leg. Clearest recording of heart rhythm on rhythm strip. Lead 3. Records impulses between left arm and left leg. Unipolar limb leads. AVR, AVL, AVF record from one pole, but due to poor illustration of waveforms must be augmented. Requires assisting in enhancing the tracing by drawing from two other poles. Lead AVL. Left leg and right arm assist with left arm tracing. Lead AVR. Left arm and left leg assist with right arm tracing. Lead AVF. Right and left arms assist with left leg tracing. Precordial leads. V1, V2, V3, V4, V5, V6 placed on the chest in front of the heart. The lead on the right arm is what color? White as cloud. The lead on the right leg is what color? Green as grass. The lead on the left arm is what color? Black as smoke. The lead on the left leg is what color? Red as fire. Limb placement. Cloud over grass, smoke over fire. Precordial leads are usually what color? Brown. What color is V1 and where is it placed? Red, right side of sternum at fourth intercostal space. What color is V2 and where is it placed? Yellow, left side of sternum directly across from V1 at the fourth intercostal space. What color is V3 and where is it placed? Green, left side of chest midway between V2 and V4. What color is V4 and where is it placed? Blue, left side of chest mid-clavicular line, 5th intercostal space. Place V4 before V3. What color is V5 and where is it placed? Orange, left side of chest anterior axillary line, 5th intercostal space. What color is V6 and where is it placed? Purple, left side of chest mid-axillary line, 5th intercostal space. Precordial placement. Read your great book of pi. P wave. Atrial depolarization. QRS wave. Ventricular depolarization. T wave. Ventricular repolarization. U wave. Not always visible but represents a repolarization of the bundle of Is and Purkinje fibers. PR interval. Beginning of P wave to beginning of Q wave represents time it takes from beginning of atrial depolarization to beginning of ventricular depolarization. SE node fires, atria depolarizes, impulse travels to AV node. PR segment. End of P wave to beginning of Q wave represents time between the end of atrial contraction and beginning of ventricular contraction. Slight delay is the time period where AV node received impulse from SA node and slows impulse to allow for ventricles to fill. QT interval. ST interval. QT interval. Beginning of Q wave to end of T wave represents time it takes from beginning of ventricular depolarization to end of ventricular repolarization, 1 ventricular cycle. ST interval. End of S wave to end of T wave, time from end of ventricular depolarization to end of ventricular repolarization. ST segment. End of S wave to beginning of T wave, time from end of ventricular depolarization to beginning of ventricular repolarization. Polarization. Resting state of the myocardial tissue in the conduction system of the heart, resulting in a flat line on EKG pattern. State of cellular rest with positively charged outside and negatively charged inside. What should be seen on a normal EKG? Universal standardization mark. Baseline tracking through middle of the tracing. No abnormal spikes in baseline. PQRST waves visible. Positively deflected waves. Universal standardization mark on an EKG. 10 mm high, 5 mm wide. How do you adjust an EKG that has a large QRS that goes off the paper? Reduced to 0.5, resulting in a standardization mark that is 5 mm high and 5 mm wide. How do you adjust an EKG that has absent P waves? This indicates elevated heart rate. Change the speed from 25 mm per second to 50 mm per second if not done automatically. Somatic tremor. Irregular spikes throughout the EKG tracing caused by muscle movement to eliminate, decrease anxiety, provide warmth. If Parkinson's, have them lay hands palms down under buttocks. AC 60 cycle interference. Regular, uniform sharp spikes, poor grounding or external electricity interfering with tracing. To eliminate, ensure proper grounding of the machine. Use 3-prong plug. Avoid crossed wires. Move bed away from the wall. Turn off unnecessary devices. Make sure filter is on. Cell phones away from EKG. Wandering baseline. Baseline wanders away from the center of the paper, making it difficult to interpret. Per electrode pad connection, lotions, oils, powder on skin, breathing, subject movement. To eliminate, clean the skin and instruct the PT to avoid using creams, lotions. Interrupted baseline. Break in the EKG tracing. Stylus has moved erratically and violently up and down across the paper. Disconnected or broken lead wire. Sinus dysrhythmia. Slight irregularity in rhythm associated with normal breathing patterns. Sinus bradycardia. Normal EKG tracing of HR less than 60 per minute. Sinus tachycardia. HR greater than 100 per minute. Sinus arrest. Break in the normal EKG. SE node failed to fire, not significant unless lasts greater than 6 seconds. Atrial flutter. Atria contracting at a rapid rate much faster than the ventricles. Atrial fibrillation. No organized contraction of the atria. Quivering state where blood clot formation due to stagnation of the blood in the ventricles is possible. Ventricular fibrillation. Ventricles not contracting but quivering, no discernible waves throughout the tracing. Immediate intervention. Ventricular fibrillation. Ventricles not contracting but quivering, no discernible waves throughout the tracing. Immediate intervention. Asystole. No rhythm, heart stopped. P-wave negative deflection. Junctional dysrhythmia. Impulse pathway from SA to AV node is not occurring and is originating from the AV junction, AV node, or another ectopic source. Premature ventricular contraction. Ventricular arrhythmia with wide and bizarre QRS wave, if occasional, can be insignificant but abnormal nonetheless, so notify the provider. Cardiac stress testing. PT is attached to heart monitoring equipment while they exercise on a treadmill or stationary bike to see how the heart handles stress. May receive thallium dye, completed in hospital environment or cardiology setting. Risk of cardiac arrest. Holter monitor. MA attaches electrodes to the trunk and provides PT education. Clean skin with alcohol and dry vigorously to make sure they are adhesive. Can apply electrodes sitting or supine. Ensure no tension in lead wires. Instruction to patient regarding Holter monitor. Resume normal activities. Keep a diary. Do not move electrodes. Wear tape if they are loose. Avoid showers. Exposure to electrical forces such as electric blanket, hair dryer. Press event monitor if they experience cardiac symptoms such as palpitations or neurological symptoms such as syncope. Cardiac event monitoring. Monitor small cardiac events over a 30-day period. Continue with normal exercise routine. Change electrodes daily. Record any symptoms experienced in the event log. 1500 method. Divide 1500 by the number of small boxes between 2 R waves. How to place tabs on arms and chest. Downward. How to place tabs on upper thighs and lower legs. Upward. Electrical impulse toward a lead. Positive waveform. Electrical impulse away from a lead. Negative waveform. Inferior view of heart. AVF 2 and 3. Anterior view of heart. V3, V4. Lateral view of heart. 1. AVL, V5, V6. Septal view of heart. V1, V2. 12-lead EKG records how many bipolar, unipolar, and precordial leads. 3 bipolar, 3 unipolar, and 6 precordial leads. Junctional escape rhythm. Narrow QRS. Ventricular escape rhythm. Wide QRS. Sensitivity of pacemaker. Extent to which artificial pacemaker recognizes intrinsic cardiac electrical activity. Purkinje fibers have an intrinsic rate of 20 to 40 bpm. Premature atrial contraction. Increase in SA node excitability resulting in premature atrial beats. Myocardial infarction. Larger than normal Q wave and elevated ST segment.